I contacted the ear, nose, and throat doctor who was going to do the surgery. And I said, this patient's hypermobile. I think we should check to see if she has Ehlers-Danlos. And he said, well, why would that be important? I'm going to do the surgery regardless.
Welcome back, every bendy body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos syndromes dedicated to helping you navigate joint hypermobility and live your best life. I am so excited today to be speaking with Dr. Eric Singman, Neuro-Ophthalmologist. As you may know from listening to previous episodes of the show, I have had lots and lots of problems with my eyes, so I'm super excited to be able to talk to someone who is so familiar with EDS, dysautonomia, mast cell activation, and all the conditions that can come along with Ehlers-Danlos syndromes and other connective tissue disorders. Dr. Singman is a neuro-ophthalmologist who lives at the intersection of the eyes, the brain, and symptoms that so many of our listeners struggle to get taken seriously. He's a professor at the University of Maryland School of Medicine and has spent decades working with patients whose vision problems don't show up on standard eye exams. Dr. Singman has held leadership roles at Johns Hopkins Wilmer Eye Institute, advised the Department of Defense and Social Security Administration, and helped shape national guidelines around disability, brain injury, and connective tissue disorders. His work focuses on visual dysfunction after brain injuries and the visual impacts of hypermobile Ehlers-Danlos syndrome, which makes this conversation especially relevant for the Bendy Bodies community. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. I am super excited about this conversation because in my clinical practice, I see so many people with convergence problems, eye pain, visual snow, and so many other eye-related conditions. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Okay, well, I am so excited to be here today with Dr. Singman. Thank you so much for joining me today on the Bendy Bodies podcast.
Thank you for having me.
Yes, absolutely. I want to start out by talking about what a neuro-ophthalmologist is, because I would imagine a lot of people are not familiar with that term. So can you explain exactly what a neuro-ophthalmologist is?
Sure. After someone becomes an ophthalmologist, after they go to medical school and then do a residency in ophthalmology, there are a number of different post-residency training opportunities called fellowships. And this allows an ophthalmologist to subspecialize. Neuro-ophthalmology is that subspecialty. It's a year-long fellowship in which someone studies intensively about the visual pathways, not just of the eye itself, but of the visual pathways of the brain. So a neuro-ophthalmologist really acts as a liaison, if you will, between the neurology community and the ophthalmology community. And the brain is about 50% vision one way or another. So it lends itself to this sort of specialty. There are not a lot of neuro-ophthalmologists in the country. There are a number of reasons for that. They're about maybe less than 600 or so. Some states don't have one. About 97% of the counties in the United States don't have one. But what we do is we try to help guide patients. I like to speak of neuro-ophthalmology as sort of, and for those people who are older, they might recognize this, the phone operator. What you used to call the phone operator, you don't want to talk to the operator. It was nice, very lovely person, I'm sure, but you want to say, hey, operator, can you get me here or can you get me there? Neuro-ophthalmologists often aid in getting the patient to the right place they're supposed to be by helping guide a diagnosis A perfect example might be with a neurologic condition that affects the whole body, but often presents with the visual system first. Multiple sclerosis is classic for this. About 40% of patients with multiple sclerosis present for the very first time. Their disease shows itself and manifests itself with an inflammation of the optic nerve called optic neuritis. And so they come to an eye doctor saying, hey, I can't see right. The eye doctor might be a neuro-ophthalmologist, usually isn't. The patient is then sent to a neuro-ophthalmologist. The neuro-ophthalmologist then helps define the optic neuritis, does some testing, recognizes that there may be a diagnosis of multiple sclerosis, and then hooks into the right specialties, usually neurology in that case. Another example might be a patient who comes in with peripheral vision loss. They're sent to a neuro-ophthalmologist. The neuro-ophthalmologist recognizes that this might be from a pituitary tumor. The neuro-ophthalmologist does the appropriate tests, confirms the diagnosis, and sends them on to a neurosurgeon, for example. And there are other examples like this: Lyme disease, rheumatoid arthritis, sarcoid disease, myasthenia gravis. There's a whole list of conditions that neuro-ophthalmologists often are the kind of the second or front line for and help the patient get to where they need to go.
Okay. And today we're going to be talking about your specialty, neuro-ophthalmology, as it pertains to EDS, HSD, and comorbidities like dysautonomia and mast cell activation syndrome. How did you get interested in EDS in the first place?
It found me. It found me. When I was working as a neuro-ophthalmologist at Johns Hopkins, and I had founded the Vision After Brain Injury Clinic for Johns Hopkins Wilmer Eye Institute, there was some patients who just didn't seem to be doing as well. And one of them turned out to have Chiari malformation, and on further questioning, they turned out to have they were hypermobile. And so another patient turned out to have Ehlers-Danlos. And so I started asking my patients about that. I started making one of my official questions that I ask my new patients, are you hypermobile?
Mm.
And by the time we finished, by the time I came over to University of Maryland, I was recruited there after 10 years of being at Hopkins. We had found 50 patients who did not know they were Ehlers-Danlos patients. And I did not make that diagnosis. I started to suspect it. I always sent them to geneticists to confirm, and the geneticist confirmed these patients had hypermobile Ehlers-Danlos or some other variant like classic Ehlers-Danlos. And so I just started to want to learn more about this condition. And as I did, patients were a wonderful resource helping me learn about this condition. We ended up surveying the members of the Ehlers-Danlos Society, got back 5,000 responses to our survey about their experience with eye surgery. We also found that, sure enough, we did a case series that Ehlers-Danlos patients don't seem to do as well after traumatic brain injury. The symptoms seem to last longer and not get as full recovery. We ended up finding other things like there was some information in the medical literature that were untrue. For example, there was at Johns Hopkins decades ago, there was a family of Ehlers-Danlos who also had another condition, and they had this retinal finding called angioid streaks. And I looked at all my Ehlers-Danlos patients. By that time, we had hundreds. They just came because they wanted to be seen. They wanted to talk, and none of them had angioid streaks. So we actually published this. And then the Mooresfield Clinic in Britain, a very famous, world-renowned eye clinic, then came with a second paper saying, yeah, we looked also, thanks to you, we didn't find any either. So it turned out that if you look at all the medical literature about what Ehlers-Danlos patients have, there was even a mnemonic made called Pepsi for those patients with angioid streaks, and they would have Paget's disease of bone, Ehlers-Danlos syndrome, sickle cell disease, and pseudoxanthoma elasticum. And turns out that the E in Pepsi didn't belong there or may not belong there. And so ruined the mnemonic, unfortunately. But So but we learned a lot, at least the hypermobile type, and we looked back at the literature, and all the people who looked at angioid streaks and published that Ehlers-Danlos patients who have it never looked at Ehlers-Danlos patients. They just published it as a matter of fact in their article because, you have to give references. And they all published that one reference. And when I look back at that one reference at Johns Hopkins, it was a family who also had pseudoxanthoma elasticum. And so they think it was not true. So, but this is how, once something's in the literature, it seems to last. At any rate, so that's how it fell into my lap. And then just after a while, I started meeting people in the Ehlers-Danlos community who were very prominent, like Claire Francomano and such. And we developed relationships and became friends. And so I started seeing more patients. So in a sense, it kind of fell on me. I didn't pursue it.
Yeah, I think that's how it happens for most of us. Your story, I think, is quite similar to a lot of people's. So, okay, what kind of symptoms make you think this is not just an eye problem, but this is a brain-eye connection issue?
So neuro-ophthalmologists are sent two kinds of patients. One is, I don't know what this is. They're complaining about something either with their vision or related to their eye. I'm sending it to neuro-ophthalmology. Maybe they can figure it out. The other kind of patient is, I know what this is. I'm a busy cornea specialist who sees 50 patients a day. I don't have time to deal with MRIs, CAT scans, and blood tests. I'm sending them to neuro-ophthalmology. So that's the two kind of patients we get. When it comes to real stereotypic neuro-ophthalmology, the patient usually either doesn't see much and neither does the doctor. So the eye doctor looks in the eye and says, "Mrs. Jones, your eye looks fine. I can't explain why you're having reduced vision or accentuated vision or glare sensitivity, or you're seeing things, or you're having pain in and around your eyes. Sorry, it's not my specialty. Why don't you see this person here and see what happens?" That's usually the common story.
And so an EDS patient should see a neuro-ophthalmologist rather than a ophthalmologist or optometrist maybe they should see those people first sometimes to rule out some other kind of problem, or when should an EDS patient see a neuro-ophthalmologist?
Almost never. I love them when they come. They're wonderful people, but I feel bad because many of them are sent to me from wonderful, caring providers that said, "Hey, you have a pair of eyes and you have EDS. You better get your eyes checked." And unfortunately, fortunately, it's really not like that. The fact about EDS is that depending on the type of EDS, there are pretty stereotypic problems they're going to get, which usually can be handled. For example, if they have brittle cornea syndrome, well, they need to see a cornea specialist. They don't need to see an ophthalmologist. If they have concussion symptoms and someone does a wheel and deal with that, that's something I often see. If they have migraines, they usually would be best with a neurologist. Now, I do some migraine work, true, but complex migraine patients I often send to neurology. Basically, I've actually put my own cell phone number on the EDS Society's website because a lot of patients wanted to come from far to see me. Well, EDS and you're EDS literate. And I said to them, first of all, thank you. I'd like to think of myself as such, but there are way more literate people than me, I'm sure. But what I tell them is, why don't you call me first and see if there's something I can do to try to help? And I don't charge for that. I'm on the phone frequently during the week simply because I want to save someone the trouble of coming in. Now, there are times I think I can help. A patient with EDS developed new onset double vision. Now, that could be a medical emergency. And so I usually tell patients if it's some new clear neuro-ophthalmic problem, they've lost vision, they have double vision, they lost peripheral vision, Get that checked out immediately. It could be emergency locally. Once the dust is settled, if there's questions, we can certainly approach them. Other kinds of patients who just want to say, well, I want a good eye exam by someone who's EDS literate. I tell them, you know something, the bottom line is what we found in EDS patients is they get pretty much the same eye problems as everyone else. Some they get more often, but ultimately it comes down to a final common pathway. So they may get more keratoconus, which is a laxity of the corneal tissues causing astigmatism. They may get it more often, or they might be more often very nearsighted. And they get problems with being very, very nearsighted. They may have more often retinal detachments or retinal tears. Well, those patients need an eye doctor, but they usually need a retinal doctor because they have retinal detachments or retinal tears. Those patients with keratoconus need a cornea doctor. Now, in fairness, sometimes nobody's told them that or nobody's diagnosed that, so that's something that, we might help with. But ultimately, we want the patient to see the right eye doctor for their particular ophthalmic condition. And usually that's in my experience for the hundreds of EDS patients who come to see me, um, I would say the majority of them didn't have a particular neuro-ophthalmic problem, at least not one that we could help. Some of them were sent to me because other doctors have kind of thrown their hands up, and I understand. A classic example is glare sensitivity. A lot of EDS patients notice that just glare is very uncomfortable, perhaps more uncomfortable than other people might be experiencing it. Fortunately, we don't know how to measure glare objectively, and we don't know how to treat glare sensitivity. And I encourage patients to try whatever they want. Now, there are some schlock snake oil people out there using all sorts of different things. I won't mention stuff, but they have to be careful about that. But unfortunately, we don't know how to deal with that. Another example is visual snow. I happen to have visual snow. I was born with visual snow, and it's just something I've lived with. I thought it was normal for me until I found that it wasn't. But the reality is visual snow, I wish we could help patients with. Now, if someone develops visual snow new onset, that could be a different problem. That's something we might want to look into. If someone has any kind of change that's new onset, where the eye exam is not obviously showing why, that's often something that is sent to a neuro-ophthalmologist, whether it's double vision, peripheral vision changes, color vision changes, etc. That's something that often is sent to us. EDS patients often also have other problems that they send to neuro-ophthalmologists pretty frequently. So EDS patients seem to have Chiari malformation more often. That can be associated with elevated brain pressure, and we're often sent those patients to look for swollen optic nerves. Now, in fairness, most decent eye doctors can determine if an optic nerve is swollen or not, but a lot of eye doctors don't want to be the one who's the final arbiter of that. And I understand that because sometimes it can be subtle. A lot of times, though, it's pretty obvious. EDS patients also have other problems that people, unfortunately, don't think of. When someone has Ehlers-Danlos syndrome, you have to, and this is what the patients want with someone who's EDS literate, is they want someone who includes in their differential diagnosis some of the extra things EDS patients might get more often. There's still bread and butter medicine things that might often. So, perfect example, an EDS patient I had recently went for chiropractic manipulation, and the chiropractor did rapid manipulation of the neck, and the patient developed a vertebral artery dissection. Now, that is a documented concern with rapid neck manipulation. It may be more common in EDS patients simply because EDS patients are more fragile and their blood vessels, therefore, are more fragile too. So that was someone who was sent to me. Another patient, for example, was a patient who was having very bad headaches. And they sent the patient to me saying, hey, Eric, could you check for papilledema because maybe it's elevated brain pressure? Well, it turned out that the EDS patient, unfortunately, a very intelligent man, very good historian, people weren't completely listening to him. And doctors see patients pretty frequently and they have to kind of get through. And so you don't, so I, but when I work with residents, I tell them when we're trying to avoid veterinary ophthalmology. So let's talk to the patient. And when you talk to the patient, we found out that his headaches are much worse being upright and much better being supine. Well, that's exactly the opposite of elevated brain pressure headaches. That's the kind of headache you get with a CSF leak. And it turned out, and there's EDS patients are more prone to spontaneous CSF leaks. And it turned out he had a CSF leak. He did very, very well after they patched the leak. He went to one of the specialty centers. I think either was Duke or it was Hopkins. They have some special, and there are some other places that are really good at CSF leak treatment. There's another one in California, a world-renowned specialist. But sometimes it's a matter of just asking the right questions. Now you might say, well, Eric, shouldn't anyone have asked those questions anyway? And the answer is probably yes. But if it's a field that it's not, we all have our little niches and we tend to be experts in our niches. And so I don't blame anyone for not asking some of these questions. I just, and the fact that they sent them to me because they worried about elevated brain pressure showed that they had some information and some background. So that was impressive. So, but some of these can be tricky.
Yeah, and I've had my share of eye problems. Fortunately, not visual snow, so that's good. But I've had very significant dry eye. I have bilateral punctal plugs. I have hypermobile EDS, and I've had plenty of problems like light sensitivity, eye pain. I can feel every little eyelash that gets in my eye. My husband teases me because he doesn't ever feel anything, it seems like, and I'm constantly looking in the mirror, and then usually I can find something, if it's an acute onset of pain in my eye, but blepharitis, whatever it's called when you have like inflammation, infection related to like the eyelids, and I've had that. I've had a corneal ulcer. I've had a lot of different problems with my eyes. I don't know how many of them are related to EDS, or like you said, they are more traditional eye problems that people with EDS are at higher risk for, and then a regular ophthalmologist, though, can treat them. I guess I'm really curious, in terms of some of these things that might occur more commonly, can an eye doctor who doesn't know a lot about EDS still manage those problems? Or, it seems like a lot of my patients are struggling to get help with their eyes.
Yeah. Well, in your particular case, dry eye, that's a huge problem. It's first of all, it's more common in women. It's more common in women as they approach the perimenopausal period, for example. And it also is more common in patients with mast cell.
Mm,
And EDS patients have more mast cell, right?
right.
When I have EDS patients with dry eye, um, I like to try topical chromalum sodium for them because they often have itchy eyes too. They notice their eyes are often itchy. And I like to try that because most eye drops, they're mostly water or some carrier vehicle which lubricates the eye, but they have an active chemical. And the active chemical in topical chromalum sodium, is a mast cell degranulation inhibitor. And so I like to see if those help. I take a very stepwise approach to dry eye, but and I'm very careful about it because my fear is that because EDS patients are often very sensitive to medications, whether that's the mast cell or something else, you have to really kind of tread lightly because you don't want the side effects to be as bad as the disease.
Right. Right.
So I usually start with preservative-free artificial tears just to see how that goes. I usually make sure there's good lid hygiene, and I usually try to help with then chromosodium, et cetera, and then I can step up to things like cyclosporin or Zezra or these other medications. I like punctal plugs, but I only like to see them put in after the tear film is made healthier, because the tear film in dry eye is pretty much a witch's brew of inflammatory products. And so if you don't clean up the tear film and make it healthier first, by putting in the punctum plugs to increase tear film volume and prevent drainage of the tear film into the nasolateral system, all you're basically doing is bathing the eye in that inflammatory brew. So that's why I use this. That's why plugs are important, but they're a little later in the game for me personally or for my patients. But then, in the same way, if an EDS patient has dry eye, I refer them to the dry eye clinic. The most dry eye clinics are pretty good with this, especially ophthalmologists who specialize in dry eye. When I was at Hopkins, S.N. Agpeck, she was world renowned dry eye specialist. And she also took this approach where she was looking to see, she didn't want to make things worse. She wanted to make things better. And so she was careful about what medicine she might apply. Um, but there's a perfect example of someone who's good at dry eye. Chances are they can handle the dry eye of EDS patients. And new therapies for dry eye are coming out all the time because it's a real problem. What I'm excited about is seeing whether hormone therapies are going to be helpful for that. We know that dry is more common in women. We know that dry is more common in the perimenopause area. We know that there are a tremendous number of estrogen receptors in the in the lacrimal system. So we know that hormone therapy is going to have to be a area of research, and it is actually an area of research, an exciting one at that. So that's where I think something new is going to come from. I think that the next breakthrough in dry is probably going to be in that sector.
And I really appreciate what you just said about dry eye because I feel like it's one of those things that is probably underappreciated if you don't have it. I feel like eyes are very easy to take for granted until you have problems with them. And all of a sudden now it's like this, all of a sudden you realize how important they are. And dry eye is something that is so common. And I feel like it's easy to just, oh, well, you have dry eye. It's not not a big deal, but it can be a really big deal for a lot of people.
It is a really big deal, and it's starting to get the recognition it deserves. And if you look at the research in dry eye, it's been exponential, and that's reassuring. I love seeing that. Some of the new medications have come out that are willing to push the envelope in terms of what therapies they use. They're probably the last 5 years, 4 or 5 novel therapies of different mechanisms of action, which is exciting. So I think that's going to continue to grow. And it's because enough people have said, you know something, you shouldn't have to know your eyes are there. You should be able to just, the way you don't know your handle, right?
Right.
EDS patients have enough pain. When I do a review of systems on EDS patients, I tell them, I used to say, what hurts? And I used to have a list of things 40 miles long. I just now ask what doesn't hurt. And it's much quicker to go that way.
It sounds like you really have seen a lot of EDS patients if you've changed the way you ask that question. Yes, that is very, very accurate for so many people. So true. What about more unusual treatments for dry eye like PRP? Is that something that you've ever prescribed or know anything about?
I don't. I send them, whether it's for serum tears or PRP, where these novel therapies. I'm a neuro-ophthalmologist. I don't want to step on toes, and I don't want to get into an area that's not my specialty. So it's my habit and custom to send them to a dry eye clinic. Who
I
knows what
didn't
they're
even.
doing? A lot of people
Right.
say they're dry eye clinics. You got to be careful.
I honestly didn't even know there was such a thing as dry eye clinics, so that's really interesting, and it's blepharoconjunctivitis that I had. And can you expand before we take a break, can you just expand a little bit on lid hygiene? Because I feel like that's something we are gonna get into neuro-ophthalmology more in the second half, but I feel like some of these basic things can probably help a tremendous number of people.
So lid hygiene is it's a twofold process. It's keeping bad things away from your face and eyelids, and it's getting rid of bad things from your face and eyes that might already be there. The basic lid hygiene for uh, Joe run of the mill who has a little bit of we call it scurf, just debris at their eyelashes. We wake up with stuff. Is when they take their daily shower, daily ablutions, they might take some baby shampoo on a washcloth, close their eyes, just scrub that gunk away from their eyelids, keeping that gunk away from their eyes, because that gunk is food. It's food for Demodex mites, which live in many people's eyelids. And if you ever see a high-power microscope, they're frightening as all get out. But
I saw
most
one for the first time yesterday, and I
it's
freaked out.
horrible. It's
They looked
horrible. It's just
awful.
like it's horrible. Parasitology is when I did parasitology in medical school, I lost about 9 pounds because I was refusing to eat anything. I was
Yeah,
scared to eat or
yeah.
drink. Um, so so also to we so that's just basic cleaning of the area. Obviously, there are things that we love patients to stay away from, like cigarette smoke or smoke from any cause, fires, um, chemicals. If they work with chemicals, chemical vapors, all of these things are just not going to be good for your eye and your conjunctiva. So avoidance of that is valuable. Many people have service jobs where they do a lot of reading on computers and such. We know that that lowers the blink rate, and the blink rate is what keeps your eye moisturized and clean. I have a feeling that some of the reason we're seeing a lot more dry and blepharitis is simply because people are having indoor desk jobs rather than outdoor jobs. Yeah, that's one thing for sure. Another thing though is that there are some illnesses that are going to make the tear film less healthy. Rosacea is the classic one. That's when someone looks like they've been drinking even though they haven't because they have a red nose and red cheeks. Certain medications, many medications actually, anticholinergic and stuff, cause dry eye. I mean, the list of medications that cause dry eye is humongous, and a lot of EDS folks are on medications of many types.
Mhm.
Um, there, there are certain things that someone could do to try to help their eye, depending on what they find. So, if they have, for example, tea tree oil wipes have been popularized and have helped a lot of people. Especially, they kill Demodex, for example. They kill the parasite, and it's amazing when people use that and kill the Demodex, how many patients with rosacea, the rosacea seems to go away, suggesting that maybe the Demodex was helping stimulate the rosacea, whether it was an immune problem or not, we're not sure. So tea tree wipes have been shown to be valuable. Keeping the eyes moist with artificial tears. If someone has mast cell, that's going to also cause inflammatory response in the tear film. And so maybe if they have bad mast cells systemically, the oral gastrochrome, if it's just topically nasal chromal sodium or topical chromal sodium in their eyes. So there's a lot that we try to do to keep bad stuff away and get rid of bad stuff that's already there, keep things healthy. Some things we can't change. Um, if a woman is going through menopause and she has fluctuations in her hormones, that can be much more difficult to change. Now, if she's put on hormone replacement therapy, there have been studies suggesting that that can be valuable for more than just hot flashes and things like that. That might be valuable for protecting from bone loss, for example, osteoporosis. That might be valuable for dry eye. So that's something that's a consideration. There are some patients who take hormones exogenously for other reasons, even if they're not going through a change of life. There are people, let's say, who want to transition from their phenotype, even though let's say they have a particular genotype of male or female, they want to transition to a genotype that's the opposite of female or male. And oftentimes that requires a hormonal intervention. That hormonal intervention, oftentimes, unfortunately, has been shown to be associated with side effects. And when it's testosterone, for example, that there are problems with it can cause other problems. I've had, besides neuro-ophthalmology problems like elevated brain pressure, but also can cause dry eye and other problems. So we have to try to look at the whole picture, the whole patient, the dry eye picture. It's a hard picture. Obviously, if somebody has certain uh, a morning routine using, let's say, a woman or someone uses makeups. Certain makeups might be allergenic, and there might be a place to avoid those, especially makeups that come very close to the eyelid margin. Those makeups might be allergenic. Some might be protective. If you look at pictures for thousands of years in Egypt, people use something called kohl, not kohl as in charcoal, but coal, KOHL. They were using those, it has antiseptic properties.
Mm.
So, there may be things that are good to put on the eyes to protect them. But unfortunately, a lot of things put near or at the eye can be pretty bad for the eyes.
So there's some people that can get away with not doing these hygiene things for the eyelids because they're not prone to having Demodex, but there's other people that have to do these things because they have dry eye and they're prone to these problems. Is that correct?
Right, and then people, a lot of people, probably the majority of the people have Demodex. Many of them are asymptomatic, but even though it's horrifying and nobody wants it in their body, but those people where they have stubborn blepharoconjunctivitis or blepharitis, it certainly is reasonable to consider approaching that issue.
Great. We are going to take a quick break. And when we come back, we are going to talk about problems with double vision, convergence, et cetera, and get more into the neuro-ophthalmology side of things that affects people with EDS. We will take a quick break and we'll be right back. As someone with EDS and who treats patients and does lots and lots of these podcasts, I am always looking for products that are going to help me be more comfortable. I want to tell you about Cozy Earth. There is nothing more comfortable than getting into a cozy bed and making being at home the very best part of your day. Cozy Earth is so confident in their products that they actually offer a 100-night sleep trial. This is insane. If you don't love their sheets, after a whole 100 nights, you can actually return them hassle-free. And they also offer a 10-year warranty. That's insane. A whole decade. So start the new year off right and give your home the luxury it deserves. Make your home the best part of life. Head to CozyEarth.com and use my code BENDY for up to 20% off. And if you get a post-purchase survey, be sure to mention you heard about Cozy Earth right here on the Bendy Bodies podcast. Give the gift of comfort that lasts beyond the holidays and carries into a cozy new year. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we are back with Dr. Singman and talking about neuro-ophthalmology, and also we were just talking about some common eye problems in EDS that are not maybe neuro-ophthalmology related, but I appreciate you letting me pick your brain about some of these things that, I think so many people experience, and they're often treated like they're not that big of a deal, but they can really impact your day-to-day life. So thank you so much for all those tips and things that you've given us. Can you explain about things like double vision, convergence, eye alignment? Are some of these things more common in people with EDS? And you've already mentioned Chiari malformation. Are these things more common in people with connective tissue disorders? And if so, what are some of the reasons besides Chiari malformation? And of course, we should explain that Chiari malformation is when the foramen magnum, or the bottom of the skull, the brain is kind of sagging through that hole, and the brain stem is affected, and the visual centers, because they are in the back of the brain, are the most important ones. So can you explain to us why these problems might be more common in people with EDS, if they are?
As far as Chiari per se, my gut feeling about Chiari is that because all the tissues in the brain are lax, it just seems more likely for things to settle because of gravity. But I'm not sure we know 100% why Chiari is more common in EDS patients. We do know that when someone does have Chiari malformation, they're more prone to having things like convergent spasm, where their eyes can spasmodically cross, and they also are more prone to having nystagmus, where their eyes jiggle. And when that happens, then the world can jiggle. That's called oscillopsia. Other kind of problems with EDS patients, and there may be a chicken and egg issue here, but EDS patients tend to have a tremendous amount of fatigue. So when I go for my review of systems for an EDS patient, I ask a couple of questions. I can't think of the last time I haven't gotten told yes. So I ask them, do you have brain fog or some sort of slowing? Do you feel cognitively you've been affected? always, invariably, I'm going to get, yes, I feel like I'm just not as sharp, especially after a trauma or something like that. In addition, I ask you fatigue, and the answer invariably is yes. And there are a couple of reasons for fatigue too. When you hurt everywhere, it's hard to fall asleep. Okay, so if you don't get good sleep, you're not going to have good energy. That's one. Also, EDS hurts. I mean, a lot, and that takes up a lot of bandwidth. And so, my gut feeling is that if EDS patients could magically feel no more pain whatsoever, especially in the neck, because the neck seems to be it's going to sound funny. I say this to my patients, they laugh at me, but it's the Achilles heel of EDS patients is their necks, right? If they can feel no pain, imagine what they could do instead of having their brain constantly being interrupted by, hey, it hurts. They could focus on other things. Pain takes up bandwidth, and that's exhausting because they still have to go through their regular day. So EDS patients have a lot of good reasons why they're going to have a lot of fatigue. But when someone's fatigued, then anything you need to do is harder. If you're fatigued and I ask you to lift a 10-pound weight versus you're feeling great, that weight, you both can lift the weight, but the endurance of how many times you can do it's going to be less than a fatigued person.
Mhm.
Convergence, which is bringing the eyes together for near work, they cross naturally when you look at the thing. That process takes a lot of work, and initiating it and maintaining it is important because, as I said, more and more people have employment where they have to look at things closer than 20 feet. If you look at anything closer than 20 feet, your eyes have to cross some. Okay, that's called convergence. And if they're insufficient at that, they have convergence insufficiency, then it's a problem. Now, I'm sent a bunch of patients saying, Eric, they got convergence insufficiency, and that's why they can't read. And many of these patients have gone to people who say they do vision therapy and spend a lot of money and a lot of time with that. And they come to me, and I had 3 patients yesterday with EDS come to my clinic in Midtown, Maryland yesterday, new patients. And every one of them had the same complaint. They were having trouble reading, and they were told it was their eyes. Now, it might very well be their eyes. But when I explain to them, I say, reading is like a chain. It's a tool, it's a chain. Its job is to connect you with knowledge. So imagine a chain made of links connected to a big box called knowledge, and you want that box. So you pull that chain towards you. Eventually, you'll get that box of knowledge. Now, supposing that chain has a broken link. Well, you don't know that. Let's say it's in a dark room. You can't tell what it. So you pull that chain till you come to the first broken link. That first broken link might be you need glasses for reading, might be you can't converge well, and you fix that link. And then you keep pulling, and you may find a secondary broken link, which might be cognitive issues that prevent you from having executive functions allowing you to remember what you're reading. So the problem with reading, because it is a chain made of different steps, you have to fix the first steps you find till you get to the next steps. The reason I give you that analogy is because many of the patients come to me being told they have a broken link somewhere in that chain, and they were told that link has been identified when it was identified incorrectly. I'll give you an example. Patient came to me, yes, they say, I want to come here. I want you to give me exercises so I can converge better, so I can read again. I said, well, why don't you think you can read? Well, my physical therapist told me I can't read because I have this. And how they measure that? And they showed me how to measure it. And they measured it by having someone look at someone's fingers that came to their face. Well, that's not how you measure convergence. That's how you measure accommodation and convergence at the same time. Accommodation is focusing your lens. And so it ended up they measure nothing. If you measure 2 things, you're measuring nothing. So I said, why don't we do a little trick? I put on a patch on their eye, or I covered one eye of their glasses, one lens with their glasses. I said, please read for me. And they were reading, and they said, this is terrible. I can't read like this. Now, I made sure I covered the non-dominant eye. I checked for which eye is dominant. I cover that to make sure I'm not making it hard. And I say, well, let me ask you this. Is this how you feel when you try to read? They say, yes, it is. See, I have convergence insufficiency. I say, well, isn't convergence insufficiency when your brain can't make your 2 eyes work together? And they say, yes. I said, well, I covered one eye. I relieved your brain of the need to work together. So how come you're still having a problem? Then they look at me and they get, oh. And that's a simple test that anyone could do in their office. Before you send someone for convergence problems, why don't you make sure, or before you tell patient, and I had patients come in, she had weeks and weeks of vision therapy. I won't say with whom, charging hundreds and hundreds of dollars to make her eyes work together as a team. And yet, when you cover one eye, the things were just as bad. So maybe there was a teaming issue, but it certainly couldn't have been the only issue, because if you prevent eye teaming and reading is just as bad, it's not an eye teaming issue. So this is the kind of thing that happens. Now, do patients with EDS get more convergence insufficiency? I find they do, probably because they're so fatigued. And if I can't fix the fatigue, I probably can't fix the convergence insufficiency. So what I tell those folks to do is to read in smaller bits, frequent small bits rather than marathon sessions, little sprints rather than long marathons. That's sometimes the best we can do. If they really have bad convergence insufficiency, of course, I'll provide exercises and such, but I'll also sometimes say, look, there's nothing wrong as a stopgap with covering your non-dominant eye so you can get through the day. It's not going to make you have a lazy eye or anything like that. That doesn't happen if you're past 6 or 7 years old of age. Now, that being said, I still want to help the patient find out why they can't read, even though I feel a responsibility. Even if I show it's not a convergence problem, I still want to help them figure out what's going on. Oftentimes, it might be a problem where they have abnormal pursuits. We can see that with Chiari as well, but it often isn't that. A lot of the times, you'd be surprised how simple it is. A lot of times, it's an executive or cognitive problem where the EDS just is not letting them do their job. Unfortunately, it can happen. The other problem I get, though, is ergonomics. When all of us were taught to read as children, we were taught to read on those big cardboard books that we used to get when we were little kids, the golden key books. And we would sit down and hold the book in our lap and we would read and turn the pages and enjoy the books. That's horrible for EDS patients because that's putting a strain on their neck. The last thing you ever want to do with an EDS patient is do anything mean to the neck. So the first thing I ask my patients when they come in and they're having trouble reading is, please tell me about the ergonomics of your reading situation. If they have a computer and the computer is not at eye level, the first thing I do is say, please put it at eye level. And oftentimes they have it at eye level because EDS patients are pretty sharp. Okay, they know a lot. They know often more about their illness than many doctors know about. I get that, but the ones who might not have explored that, you get a really big bang for the buck for some of these things. But sometimes we can't find why the reading is a problem. But at the very least, as a physician, I take a Hippocratic oath: do no harm, and that includes do no harm to the pocketbook. So at least the EDS patients who come into me saying, well, my doctor wants me to have 18 more weeks of vision therapy for my convergence, I can tell them at least, you could save the money, give a little to charity and save the money for something else that you like instead. Because how could it be helping if your one eye reads just as bad as with two eyes open? That kind of. So those are some of the things we see. Now, frank double vision, we can see with EDS too. I've seen that with certain problems. Especially when they have elevated brain pressure. Elevated brain pressure not only can cause papilledema, it can cause a cranial neuropathy of any cranial nerve. I had an EDS patient who someone actually didn't know they had EDS. They came in to see me with new onset papilledema with intracranial hypertension, elevated fluid pressure in the brain, and they came in with a Bell's palsy. And they did a workup before they saw me for Lyme disease and herpetic disease and stuff. But in fact, no one looked at the back of her eye. They sent her to me, and they sent her to me actually just because one of the tools that I have as a neuro-ophthalmologist are these external lid weights that I can prescribe for a patient. Now, anyone could prescribe. They're made by a company called MedDev, MED-DEV. They're called Blinkies, BLINK-ECE. They're external lid weights that go on with a double stick tape, and they can help the eye close when a person who can't close their eye helps them close their eye. They're very simple. They're not expensive, but I prescribe them all the time. I have a fitting kit in my bag. In the meantime, I examined them, a full exam, and I found they had swollen optic nerves. It's called papilledema. And I spoke to them, and turns out that they had elevated brain pressure called intracranial hypertension. And it presented actually with the Bell's palsy. We lowered the brain pressure successfully medically. And then I started to ask this patient some questions. And the reason I started to ask her some questions was I looked at her age, and her age said she was like in her 40s, but she looked like she was in her 20s. And it's become a habit of mine when I see a patient who looks much younger than their stated age to ask them if they're hypermobile, because it seems to be very common with Ehlers-Danlos patients that they simply look younger than they are. And, she appreciated the compliment. She thought I was just being nice. But she said, "Well, that's so nice of you. Why I asked you?" Well, I said, "So I did a bite and score on her right in the clinic." And she said, "Yeah, I've always had double joint. I've always been double jointed." I mean, she could bring her thumb to her wrist. She could put her pinky so far back. In fact, it turned out she was also at one point a gymnast, because she was so flexible. And many of those patients, yes, I was a gymnast, a cheerleader, martial arts, a dancer, something like that. And so she said, "Yeah." And so I started asking more questions, and it turns out she had a history of uterine prolapse, which you can see with Ehlers-Danlos, and she had even a rectal prolapse. She had a history of hernias. She just thought she was unlucky. And she said, "Yeah, my mom always had that too. I got that from my mom." And so I spoke to her about Ehlers-Danlos, and sure enough, ultimately, we diagnosed her with Ehlers-Danlos in part because she looked so young, but also because she had neuro-ophthalmic problems that we see with other people, what we see with Ehlers-Danlos too. Ehlers-Danlos folks have a funny way of having elevated brain pressure, and that when they have high brain pressure, they sometimes blow a hole out, and they go from a spinal leak to elevated pressure to spinal leak, and so the spinal leak actually normalizes the pressure, but then it builds back up. So they go through this fluctuation of high pressure, low pressure, high pressure, low pressure. I was sent a patient at the rehab hospital I work for. They have developed a spontaneous CSF leak from their nose. And they would send me the pressure because the doctor said, "Eric, check for papilledema because I want to know if she's one of those cycling patients." Now, the patient did not have papilledema, but the patient did have a spontaneous CSF leak. And I asked about Ehlers-Danlos. The patient never heard of the condition before. But sure enough, the patient was hypermobile. And I contacted the ear, nose, and throat doctor who was going to do the surgery. And I said, "This patient's hypermobile. I think we should check to see if she has Ehlers-Danlos." And he said, "Well, why would that be important? I'm going to do the surgery regardless." And I said, "Well, it's important for a couple of reasons in my experience. One is they tend to be more sensitive to medications, including anesthetics. And just in my experience, and maybe it's limited, maybe it's anecdotal, but also they tend to heal less well. They tend to heal slower. And so, at the very least, if they do have Ehlers-Danlos, you want to give them a reasonable, informed consent that, if something goes wrong, you're actually protecting yourself by recognizing they have Ehlers-Danlos. You're not just helping them. And he agreed, and we had the patient checked, and he did give the patient very good informed consent, saying, just again, we found with eye surgery, they get the same problems, just maybe more often. So he just assumed that he just gave all the different ear, nose, and throat problems a repair of a CSF leak might have. He was just more careful about it. It turns out she ended up having Ehlers-Danlos syndrome. So the one thing I've learned about with Ehlers-Danlos syndrome from the study we did from surveying thousands of patients who had eye surgery was that, as I said, they seem to have the same complications. They don't, and what else? They don't have unusual, unique complications. They just seem to have them maybe more often. And so that's why it's important to maybe be extra careful listing all the complications a person could have to an Ehlers-Danlos patient, just to protect them and yourself as a physician.
Boy, I wrote down a whole bunch of notes as you were talking to. I want to follow up on number one, papilledema. Is that something that if there's high pressure in the brain, will you see papilledema right away, or is that a late sign? Like, can you have high pressure in the brain without having papilledema?
Yes, and you can have it chronically. That's called pseudotumor cerebrae sine, S-I-N-E, papilledema. It's Latin for without papilledema. I have in fact, I had a whole series of patients when I was in private practice in Lancaster, Pennsylvania, of pseudotumor cerebrae without papilledema, and I had to actually work hard to make people believe this was even possible. Eventually, I got validated when I sent a bunch of patients down to see Mike Williams, who at the time, he's a big neurologist and specialized in cerebral spinal fluid hydrodynamics. And he was at Johns Hopkins running their CSF clinic. And he published a paper of 10 patients who had uh, pseudotumor cerebrae without papilledema, and he confirmed it using indwelling lumbar catheter. It's like having a lumbar puncture, but it stays in place. And of the 10 patients, 4 were mine. And so, he actually sent me a copy of the article that came out, handwritten. Thanks so much for your help with these. Very, very pleasant person. But the bottom line is you can have pseudotumor cerebral without papilledema. Now, if papilledema is going to happen, it could happen pretty quickly. We're talking over certainly, weeks, if not days. The funny thing about papilledema is also a lot of it can go away within weeks also, even perhaps days, but certainly weeks. But in some patients, it can take months to totally go away. One of the problems with that situation is if I see a patient who I never met before and they're sent to me and they have swollen optic nerves, I don't know what their normal baseline looks like.
Sure.
So once the nerves come down, I have to go, I make it a point to go through a number of different evaluations to confirm and prove to myself as well as to them that we're at their baseline, even if the nerves look a little bit still elevated. I get a sonogram of the nerves. I might get a visual evoke potential to see if the nerves are unhealthy. I might get a fluorescein angiogram of the nerve, which is we inject the dye in the hand and it's a safe dye. It's a vegetable dye. It glows green. We take a picture of the back of the eye to see if the nerve leaks. So there, I go through a lot to make sure before I tell a patient your papilledema is gone. I go through a lot, and I see them despite that with serial OCT pictures of the nerve called an OCT to make sure things are stable, visual fields. Once I'm comfortable that they've been stable for maybe a year, then I can tell them they can go back to their regular doctor or they can go down to our step down Neuro-Ophthalmologist care, who's a wonderful optometrist, who I'm working with to try to give me some breathing room because I'm actually booked out for months for new patients. One of the reasons I gave my phone number on the website actually is if a patient actually has to see me and there's a real problem, I'll find a way of getting them in if it's an urgent situation. But that's an example of papilledema. It can be very tricky because there are things that can make things look like papilledema that aren't, such as something called optic nerve head-drusen. These are things, the little concretions of the nerve that can make a nerve look swollen, but the nerve was fine.
Wow. So, first of all, I want to say that is incredibly generous that you have your phone number on the website. That's amazing. That's so generous that you do that and that you get people in if they really need to see you. Um, I'm so glad that you clarified about the papilledema because I know so many people who have signs and symptoms consistent with elevated intracranial pressure, but they go to an ophthalmologist, and because there's no papilledema, they say you can't have elevated intracranial pressure because there's no papilledema. So you just
It's
clarified that
sad.
point. Yeah, it is sad.
And just as an aside, uh, it's important to recognize that even if they don't have elevated brain pressure on a spinal tap, they could still have elevated brain pressure. Every patient's different. One of the things Dr. Williams shows is that there are things called B waves. The CSF pressure fluctuates widely throughout the day. So the way so let's say a patient gets a normal number on the spinal tap. Oh, you can't have it. See? No. If a patient has bad headaches and you do a spinal tap and it relieves their headaches, and then the headaches slowly come back as the CSF pressure builds back up because you likely drained off some CSF, they have elevated brain pressure. I don't care what the number is. They have elevated brain pressure because nobody volunteers for a spinal tap unless it makes them feel better.
Yeah, no, that's super interesting. And then Also, I did want to just make a quick side note about, yes, people with EDS, definitely in my experience, also more sensitive to medications, totally agree. I don't know if you've experienced this or not, but there's also this phenomenon with hypermobile EDS and HSD of local anesthetic resistance. So they tend to be less responsive to local anesthetics. They may need more. They may need a different local anesthetic like mepivacaine or articaine. They might need more frequent dosing. They might need a longer onset time, et cetera. So I just want to put that out. And then the other question that I had was, yes, so many of us spend so much time looking at a computer, and I definitely have noticed if I'm on the computer way more than I would like to be, and at the end of the day, yeah, I think it, can cause your eyes to hurt, your head to hurt. Is it a good idea for us to step away from the computer? I mean, I imagine that it is, and look off in the distance, like step away from the computer and not just go looking at a phone because that's like, right? That's not gonna help us. But are there certain habits that we should try to get into that would help with that?
Yeah, there's something called the 20-20-20 rule, which is every 20 minutes, you take a 20-second break and look at least 20 feet away. I think that rule is it's a cute name, it's a cute rule. I'm sure for most regular people, it's probably okay. I like my EDS patients. I tell them, look, you got to get some fresh air and sunshine. I tell all my patients that, frankly, uh, it, you got to get out of there. Well, I tell that to my EDS patients for two reasons. One is EDS patients, especially younger patients, probably have a higher risk of becoming high myopes. And there's pretty good data to suggest that you need fresh air and sunshine to slow down that myopic progression. And that looking at screens all day is gonna make things worse. But yeah, I tell being in front of screens all day is not good for you. We're forced to do it. Our service industry is such, even medicine's like that nowadays. I mean, I type all my own notes, and all the notes are electronic, and I might spend 3 hours going over my resident's notes in an evening. We have tons of unpaid computed time.
Yeah.
But I agree with you. That's why using the phone, if using screens for work, if you have to, you have to. But using them for entertainment, I would urge people to avoid that. Or if they have to use it for entertainment, do something that's where the screen is much further away than your hand or your desktop.
Yeah, and your point about getting outside, I think is it's so easy nowadays for us to become, so many of us work from home. So, and we end up, I was literally just talking to somebody about this the other day. It's like it gets harder and harder to actually get out of the house. I'm so glad you mentioned that because I think that's something that can be psychologically beneficial as well as, just so many benefits being out in nature and then we're looking off, more in a distance and everything. So yeah, thank you for mentioning that. And I also wanted to ask while we're before I ask the next question, and I'm cognizant of the time, we're going to have to wrap up before too long, which we might have to do a part two because there were so many of the other things I still wanted to ask about. You mentioned about charlatans and about people being talked into getting 18 sessions of vision therapy or more or whatever. How can people best reduce their chances of being taken advantage of in that way? Because I feel like EDS now has become like a gold rush, and lots of people are putting it on their website, and they're saying, "Oh, I'm sure that some people say, oh, I have vision therapy for EDS patients or whatever it might be." How do people best make sure that they're not missing out on an opportunity that could help them to benefit, but at the same time they're not wasting their money?
First thing is that if somebody's offering some sort of therapeutic benefit, I would tell a patient, because my EDS patients to invariably are very bright people and very aware people. I would say go on to PubMed.gov and look at the research in that area and see if it's find a Cochrane review or find some review or research to see whether or not the therapy being offered has a sufficiently large scientific background to make it real, or is it something dumb? The other thing is, I would patients have to be willing to ask um, other providers for their opinion, not in the same field. So let's say, if someone says, I'm a wellness doctor and I'm going to do all this wellness stuff for you. Well, that's fine. But if the doctor says I'm going to do all this wellness stuff for you, but I'm the only one who can do it, and you have to buy your stuff from me, and it's expensive, then you have to start wondering, is it true that you have a monopoly, or is it I'm always concerned that the person who tells me I need something is the person who's gonna get financial benefit from that need, which is why, I'm very hesitant when I go to a mechanic for my car. I know nothing about cars, but I'm very hesitant. Or when I go to a dentist, no offense to dentists. I mean, I dentists were friends of mine, but I'm very hesitant because you tell me I need this, but so what's gonna happen if I don't do that? So the second question to ask is what's gonna happen if you don't take the therapy that the person's providing? Is it gonna kill you? Is it gonna make your life miserable? Are you gonna get worse? Things like that. And sometimes it's a matter of trust. If, the only provider for a particular service is in your town, you live in a small town, it can be hard because that's the only reference you have. But there are other references. There are places. One of the things I admire about the EDS community is that they're very, really excellent at social networking and social media. And so if you throw a question out there for XYZ, you're bound to get some pro and con opinions of something. And you can ask those pros and cons what they think and why. And so you can get more of a balanced thought process or thought processes of people who've been there. And that can be real handy for people too.
Yeah, because I feel like, there's a lot of people now that are after the pocketbook of people with EDS, and a lot of people with EDS are on disability or other things, and so they have really limited funds, and yet they can, be talked into doing things that maybe are not beneficial.
Well, perfect example. I apologize, but a perfect example is I buy my glasses online, and I'm a -3 myop, so I'm somewhat nearsighted, and I buy single vision glasses. I don't buy any of those fancy coatings or anything, and my glasses cost me $9. And patients come to me, say, "I spent $300 for my glasses." And I say, "Why?" "Well, the doctor prescribed these glasses, and he said I could buy them right here in his shop, and they were $300." And so that's a perfect example of, wait a second, and what do these glasses have in them? Well, they have a special tint for this, they have a special coating, they have a special, micro prism in them that does all these different things. And I'm saying to myself, it makes me kind of feel, gee, I wish you would have talked to me first. And I'm probably gonna get shot for this. My practice has an optical shop. University of Maryland has an optical shop. I'm not gonna lie, you know, if a patient says, I have my pupillary distance, which is the one measurement that you need if you're gonna get glasses online, I measure it and give it to them. I don't steer them away from the optical shop. If they saw a pair of frames they love, go enjoy. But if they say, "Doc, I like your glasses. Where'd you get them?" And I tell them where I got them, one of the online sites, and they said, "Well, how do I do that?" "Well, you need your prescription." "Well, I have my prescription." "Well, you also need your pupillary distance." I'll measure it and give it to them. It's like, like I said, do no harm. That includes the pocketbook. Anyway, I apologize, I interrupted, but that was just one example. I don't think opticians are charlatans, but I do think that glasses are marked up so much by thousands percentages that it's starting to it can make someone uncomfortable.
Yeah, I got my glasses at Costco recently, and, so not online, but they were, I'm sure, a fraction of what I would have paid otherwise, and I'm very, very happy with them. So I think finding
I'm a
these
Costco
places.
member myself.
Oh, are you? I love Costco. Yeah. They did a feature May of 24, I believe it was. I don't think it was May of 25, about EDS. I was interviewed, and so were some other people about EDS, and so I was very happy that they did that
I
because
got you in their magazine. I saw it in the
you
magazine, in
saw
the
it.
Costco
Okay,
magazine.
cool.
I saw it.
Yeah.
I saw
Yeah.
it.
Yeah. Amazing. Okay, so before we wrap up, I guess I would love to know if there's other things that we should be aware of when it comes to conditions of dysautonomia like POTS, postural orthostatic tachycardia syndrome, as that pertains to vision. And also, if there's anything that we talked about mast cell activation syndrome a little bit in the beginning, but if there's anything related to mast cell activation syndrome, cervical instability, I know this is like a massive question, but if there's anything that you're like, oh, yeah, we should probably mention XYZ or inflammation or something like that. Um, like I said, we're probably gonna have to come back and do a second part if you're willing. But yeah, if you have some parting suggestions before we wrap up.
POTS, the big thing about POTS that I deal with is that in many of the things with EDS, the visual system is a bystander, and it's an innocent bystander that gets affected. It's collateral damage. So the POTS doesn't specifically damage the visual system, but when someone has, um, a sudden drop in blood pressure and that to their brain, then one of the things they're going to recognize often is that they're going to have less blood flow to their occipital cortex, and they may notice that the world gets dark and kind of cones in, or they may notice when they recover, they may notice sort of visual symptoms and phenomenon. So that's nothing I can do about. Um, Perfect example of being the neuro-ophthalmologist. A patient came in to me who didn't know they had POTS, and they described those symptoms. And I said, "I'm wondering if you have POTS." And we sent them for that. Turns out they did have POTS. They knew they had EDS, they didn't know they had POTS, it wasn't on their radar, but it turned out they did have POTS, and it was their visual changes that gave us a hint that it was POTS. So that's just an example. So, and most of the other things too, like, the mast cell, the collateral damage might be dry eye, but so that's something so that we try to help with. Some of the other things like CCI, the instability, I guess the most important take-home message I could even think of when it comes to EDS patients, and I've seen it time again, is that I almost feel like my hands are tied if an EDS patient's neck is in bad, bad shape. Because when an EDS patient's neck gets better, I've seen it time and time and time again that everything else seems to fall into place. It's almost magical. It's like I had an EDS patient whose neck got better. I forget what I don't know if they either had surgery or no, actually no, it was a patient who said, I suggested it was a patient that said, just for the heck of it, I want you to try wearing a brace. Just see what happens. And they wore a brace and they were telling me they love the brace. I said, okay, now just understand the brace is not the cure. The brace is like a temporizing measure. But the fact that the brace helped suggested that they could experience that kind of help if there were interventions that were more permanent, right? But but that reminded me how when the neck is less bad, not even cured, is when the neck is improved, so many other things with EDS seem to fall into place. The reading improved, the headaches improved, the brain fog improved, the POTS might have improved. It's just crazy. And that's why I say that the neck is the Achilles heel of EDS patients. And so when they come to me after traumatic brain injury or whatever they come to me for, and they say, "Doc, I feel like crap, and my vision's like this, and my reading's terrible." I say, many times, I basically the best I can sometimes do is hold their hand and say, "Is let's what have we done so far to try to get the neck better? Because by getting the neck better, I got a feeling we are gonna have more without me. You're gonna have more success. You don't need me for the success you're gonna have. You need the neck doctor to make you feel better." Unfortunately, sometimes I feel like if it's because the visual system is suffering collateral damage from the neck, there's nothing the eye doctor is gonna do except refer them to a good neck person. And unfortunately, those can be hard to find.
It's so great that you have such vast knowledge, clearly you have such vast knowledge about EDS and the comorbidities, and, are you willing to do a second part so we can address some of the questions that we didn't get to?
Sure, I think we could find time for that. Although I got a feeling, we covered a lot. If there are particular questions that you have or a series of them, I'd be happy to, add them if you want to post them on your website, if that would make it easy for you too.
Sure. We could look to do something like that. So the reason I wanted to ask it now is because if someone's listening to this and they think, oh my gosh, I wish she had asked X, it could have been something that was on my list. If you're listening right now and you're like, oh man, I really had this pressing question, you can send it to me, send it to bendybodiespodcast.com. Dr. Singman and I will figure out we'll figure out some way that we can get more questions answered, I guess is the bottom line. This has been such a great conversation. Do you have a hypermobility hack for us?
Don't hit your head, please.
Yeah, we didn't really
Wear
talk about
helmets.
concussion. Yeah.
No contact sports. Please, no contact sports. Swim, yes. Anything else, be careful.
Sounds good. Where can people learn more about you?
I have a lot of articles published on PubMed, and I have some of the articles about EDS, and so that's a good place to start.
Wonderful. And you're obviously on the EDS Society website, and we can include that link. So I'm so grateful to you for taking the time to chat with me today. I know that you're extremely busy, and I really appreciate you sharing so much knowledge and wisdom with me and with the Bendy Bodies listeners.
Thank you.
Well, I really enjoyed that conversation with Dr. Singman, and I hope that you did as well. The field of neuro-ophthalmology is so interesting, and he, of course, also generously shared with us general ophthalmology information as well for people with EDS, POTS, and mast cell activation syndrome. Thank you so much for listening to this week's episode of the Bendy Bodies podcast with the Hypermobility MD. I have lots of other resources, including my newsletter, The Bendy Bulletin. You can check that out on Substack at hypermobilitymd.substack.com. You can help us spread the word about connective tissue disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex and multidimensional conditions. Did you know that I also offer one-on-one support for both clients and healthcare professionals? Whether you're living with a connective tissue disorder or caring for someone who is, I've got your back. Check out my coaching and mentorship options on the services page at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at HypermobilityMD. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can find full video episodes up every week on YouTube at Bendy Bodies Podcast. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements shared on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider for your own care. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.